Together with other founders, we have been working on this clinical setting for a long time. We have completed several studies with the objective of better understanding the immune responses after organ transplantation. We have also identified biomarkers to predict tolerance, but more importantly, we have developed and applied new technologies and therapies to induce graft acceptance without the need of immunosuppressive drugs. In this journey to find a way to tilt the balance in favor of immune regulation, we aim to increase the frequency of Tregs either by infusing ex vivo expanded cells or targeting the in vivo proliferation of circulating Tregs with low-dose IL-2. With these initial trials, we demonstrated the feasibility and the safety of the Treg-directed therapies in the liver transplant setting. However, the low specificity of these polyclonal approaches significantly limited their therapeutic efficacy. Among the technologies that we have had on our Quell product, we have included a chimeric antigen receptor targeting the donor antigens, which provides a specific activation of the Tregs in the liver graft. This improvement, based on multiple preclinical models, it should significantly increase the odds of therapeutic success. The use of engineered Tregs in liver transplantation has multiple advantages compared to other transplantation or autoimmune settings. First, the abundant clinical experience in immunosuppressive drug withdrawal performed in liver recipients has demonstrated that the progressive reduction of drugs is safe and has minimal risk of graft loss in case that the tolerance is not achieved. This makes the liver setting really attractive since we can attempt the complete removal of the immunosuppressive drugs, bringing a true clinical value and at the same time the possibility to fully evaluate the therapeutic efficacy of our product. In addition, the regenerative nature of the liver allows the regular access to tissue biopsy without impacting the graft function. Access to the tissue sample will allow us to assess the localization and the phenotype of the infused cells in the target tissue and compare it to the peripheral blood, generating really valuable information to better understand the performance of our product, such as the trafficking, the persistence, and even the function of the cells that we have infused.
So liver transplant is a life-saving intervention for patients suffering from very severe liver diseases. However, a lifelong treatment with immunosuppressant is required to avoid graft rejection. And due to this long-term treatment in those patients, 3/4 of deaths are related to drug adverse events. And the percentage of survival at 10 years is not higher than in many cancers, such as breast cancer. So Quell objective is to make a complete cure for those patients. We are aiming at promoting long-term tolerance to the graft by injecting patients' own Treg engineered to specifically induce a tolerance to the graft, allowing complete withdrawal of immunosuppressants and leading to improvement of patients' quality of life and survival. We targeted ALS and type 1 diabetes because for those two diseases, there is both a clear rationale to target inflammation and a clear value proposition with our technology. In type 1 diabetes, the patient management represents an annual cost of around £2 billion in the UK alone. In those patients, the difficult lifelong management of blood sugar level can lead to many complications. And an early intervention using CAR-Treg to maintain the beta cells would allow to give them a normal life without insulin and without complications. The rationale to use CAR-Treg in type 1 diabetes is supported by preclinical data generated in 2005 by Elmar Checker's lab, one of Quell's founders, demonstrating that type 1 diabetes can be controlled by Treg with a relevant antigen specificity. ALS is a progressive neurodegenerative disease leading to damage to neuromuscular junction. The ALS patients progressively lose their ability to speak, to move, and to breathe. And under the best standard of care, the average life expectancy is of 2 to 5 years from diagnosis. There is thus an enormous need for treatment in ALS. As for other neurodegenerative disease, it has been described that neuroinflammation is at the heart of the pathogenesis of the disease. And using CAR-Treg, we aim at controlling this neuroinflammation in order to prevent further damage of the motor neuron.